Welcome to the Time to Treat educational video. You'll learn about the importance of early and intensive treatment of diabetes. I'm Carla. You just saw some of the startling statistics around diabetes in the United States. Next, Dr. Kroll will talk about effective ways to help your patients achieve good control of their diabetes within the first year after diagnosis. Then comes me, my favorite part. You'll see what my life will be like over the course of 20 years with an approach to diabetes care that is passive and less proactive in terms of reaching important diabetes treatment goals. Then you'll see me over the course of 20 years when I've had proactive care that has helped me reach my diabetes goals sooner and where I'm truly a part of my healthcare team. I'll see you later.
Hello, I am Dr. Greg Kroll from the Department of Internal Medicine at Henry Ford Health System in Detroit, Michigan. I know how important it is for a patient to receive early and intensive treatment for diabetes. Without it, a patient could experience major negative effects and is likely to continue living with an increased hemoglobin A1C greater than 8%, resulting in prolonged hyperglycemia. An accelerated decline in beta cell function is likely to follow, with an increased risk for microvascular and macrovascular complications such as blindness, kidney disease, heart attack, and stroke. Ultimately, this patient is at an increased risk of premature death related to diabetes. An early and intensive treatment following the diagnosis of diabetes can change the course of diabetes progression. Glycemic control at this stage helps create a type of positive metabolic memory and preserves beta cell function, which together support longer-term maintenance of normal glycemia with reduced need for pharmacologic agents. There are 4 important treatment goals for people newly diagnosed with diabetes: glycemic control, as measured by hemoglobin A1C, blood pressure normal or hypertension control, lipid control, as indicated by LDL cholesterol level, and non-use of all tobacco products. The Centers for Disease Control and Prevention, Division of Diabetes Translation, calls these the ABCs of diabetic care, an easy way to remember them. At least half of all patients with diabetes meet at least one of the ABC's treatment goals. When we look at any of the treatment goals in isolation, it appears that we are doing okay. However, for optimal health, we need to consider the big picture and look at the combination of the treatment goals. Only 14%, slightly more than 1 out of 10 people with diabetes, have reached all 4 of these treatment goals. We certainly have a lot of opportunity for improvement when we look at care this way. Clinical inertia has been identified as a factor contributing to patients not receiving adequate chronic disease care. It is defined as lack of treatment intensification in a patient not at evidence-based goals for care. You can help by first understanding what clinical inertia is, and then by making changes to facilitate patients meeting their treatment goals quickly, especially for those newly diagnosed with diabetes. Literature shows that clinical inertia was present in type 2 diabetes management, and that clinical inertia served as a barrier to quality care and positive health outcomes. In fact, one study showed that clinical inertia related to management of the ABCs of diabetes care contributes to nearly 80% of heart attacks and strokes. Clinical inertia is a complex phenomenon influenced by the positive and negative interplay of physician, patient, and office system factors. Primary physician factors include overestimation of care provided, use of soft reasons to avoid intensification of therapy, and lack of education, training, and practice support to achieve therapeutic goals, especially as these factors relate to early and intensive treatment. Patient factors related to clinical inertia include denial of disease, the perception that the disease is not serious, and medication non-adherence. The latter reflects many patient challenges and barriers, including medication cost, not understanding complex medication regimens, too many medications, and medication side effects. Office system factors related to clinical inertia include lack of decision support available to clinic staff, absence of a team approach or coordination of care, poor physician-to-staff communication, inadequate visit planning, such as failure to schedule follow-up or routine care, no active outreach to patients with delivery of care only triggered by the patient initiating the visit, lack of availability or understanding of clinical guidelines, and absent or inadequate data to monitor care and identify patients in need of more intensive care. Examples of these include disease registries often available with electronic medical records. Let me repeat, clinical inertia is defined as a lack of treatment intensification. Given the multiple and complex factors that contribute to clinical inertia, a combination of approaches are required to overcome it. Through this video, we will illustrate how proven approaches can be implemented. These are often called health system changes. You may also know them as care or practice transformation strategies. These strategies are changes in office policies, procedures, structures, and supports that make it easier for healthcare providers to provide quality care and help patients to become engaged and activated in their care so they can better self-manage their diabetes. One strategy is the use of multidisciplinary teams in primary care offices. This involves clearly outlining the roles of each team member, communicating the objectives of the new workflow to all team members, providing training regarding the roles for each team member, and creating a visual of the process flow for staff to see. Furthermore, staff is trained and empowered to assess and address any barrier to a patient getting care. Another care transformation strategy that is effective in combating clinical inertia is frequent, routine, and carefully planned visits to a welcoming office environment. Such visits create more opportunities for physicians to intensify care and increase patient education and adherence to recommended pharmacotherapy. Carefully planned refers to the use of structured office workflows, which facilitate scheduling and the attainment of clinical goals and outcomes. Clinical decision support is another care transformation strategy that has been demonstrated in the scientific literature to be effective with combating clinical inertia. Decision support tools provide information shortly before or during the visit to guide providers to appropriately intensify therapy in order to help patients achieve their treatment goals. These are not just prompts or reminders. They are based on specific plan of care protocols tailored to each patient's unique needs and goals. Decision support tools can take the form of printed flow sheets or be part of an electronic health record. Visit resolution and accountability tools are yet another care transformation strategy demonstrated to be effective in addressing clinical inertia. These tools direct attention to proper drug intensification and prompt the provider to give useful documentation if recommended changes were not made. Most of our discussion on clinical inertia has focused on the provider and office factors. We know, however, that there are several patient factors that impact clinical inertia. Patient education and feedback are extremely important to prevent clinical inertia and can help to increase early and intensive treatment for patients with diabetes. Examples of this include tools to help patients set the agenda for the visit, educational resources and videos to help the patient understand the medication or lab values, and all members of the clinical team, including the provider, giving positive feedback and motivational strategies at every visit. In addition to helping patients understand the serious nature of the disease, patient education and feedback can help physicians better understand their patients and avoid making judgments about their willingness or motivation to manage their diabetes. Now, let's look at how early and intensive diabetes care can be provided to people newly diagnosed with diabetes. The following care recommendations are based on the 2014 American Diabetes Association Standards of Medical Care for Diabetes. The provider and patient, along with other members of the health care team, should develop a comprehensive care management plan that identifies treatment goals, strategies, and timelines. At all A1C levels and throughout the treatment protocol, it is imperative to recommend healthy eating, weight control, increased physical activity, and other behavioral changes such as quitting smoking and reducing stress. Individuals should be given specific targets to meet by the next office visit based on the patient's medical history, physical exam, and laboratory assessments. I would like to emphasize that it is important to stress that your patients must take an active role in their care. In order to intensify treatment at the appropriate time, the American Diabetes Association recommends the following steps. Aim for an A1C less than 7%. Keep in mind, though, that the A1C goal, as well as the choice of treatment agent prescribed, must be based on patient characteristics like age, life expectancy, duration of diabetes, cardiovascular disease, advanced microvascular complications, hypoglycemia, and individual patient considerations. When A1C is greater than 7%, initiate drug monotherapy. If after 3 months, with persistently elevated levels of A1C and continuous monotherapy, add a second oral agent or insulin. In patients with mild to moderate hyperglycemia, typically A1C greater than 7.5%, consider agents not associated with an increased risk of hypoglycemia and agents that address pathophysiology of diabetes, including treatment of beta cell dysfunction and insulin resistance. Meta-analysis literature has shown a patient can lower A1C by 0.9 to 1.1% with each new class of non-insulin agents that is added to the initial therapy. If the A1C goal is not met within another 3 months, proceed to a 3-drug combination. Remember, the goal is to achieve glycemic control as soon as possible after the diagnosis and ideally within 1 year. If a 3-drug combination therapy, which includes basal insulin, fails to achieve A1C goal within another 3 to 6 months, proceed to a more complex insulin therapy, usually in combination with 1 or 2 non-insulin agents. Early conversations with the patient about the progressive nature of diabetes and treatment therapies should include discussions about the beneficial and eventual use of insulin. Initiation of insulin should not be framed as a threat or a failure and need not be considered the therapy of last resort. As you work with the patient to achieve glycemic control, keep in mind that the benefits of early and intensive treatment for diabetes should be weighed against the potential risks. With benefits, there are also risks. 2 significant risks of diabetes treatment intensification are hypoglycemia and weight gain. Risk can be minimized by tailoring clinical targets and pharmacologic treatments based on a patient's age, lifestyle, duration of diabetes, cardiovascular risk, and previous glycemic control. In addition to focusing on blood sugar, always remember to treat the whole patient. It is important to simultaneously include other factors into their plan of care. This includes hyperlipidemia, hypertension, albuminuria, aspirin therapy, smoking cessation, and psychosocial factors which may impair patient activation and intensification of treatment. Lastly, referral to an endocrinologist should be considered when any of the following are present. The goals of diabetic therapy are not attained, control appears to be worsening in spite of best efforts, frequent hypoglycemia or hypoglycemic unawareness, insulin pump considerations, pregnancy planning and management, and type 1 diabetes. A referral to an endocrinologist for considerations of advanced monitoring, additional education, and personalization of care is always appropriate. Earlier, you met Carla, a woman undergoing treatment for diabetes. Let's take a look at her life when her healthcare team takes a passive approach toward her condition.
Carla is in her early to mid-50s, overweight, a current smoker, and a prior diagnosis of borderline hypertension. Recently, she presented with symptoms of increased thirst, urination, and fatigue for the previous 6 months. Her healthcare provider suspected diabetes as the cause of her symptoms. A hemoglobin A1C level was measured and was 9.1%. Her diabetes diagnosis was confirmed on repeat testing, and follow-up was arranged with Carla within 2 weeks to discuss her lab results, which included an elevated hemoglobin A1C, elevated LDL cholesterol levels, and blood and urine tests to assess baseline kidney function and screen for albuminuria. Her blood pressure on follow-up was 150/88, and she reported smoking about 1 pack of cigarettes a day. Let's review the treatment recommendations Carla's healthcare provider made. Her healthcare provider recommended creating a diabetes management plan that included lifestyle modifications, such as healthy eating, physical activity, weight loss, and smoking cessation. Prescription medications, including an oral anti-glycemic agent, an antihypertensive agent, and a cholesterol-lowering agent. To address dietary changes, Carla was given a few handouts with general recommendations for individuals with diabetes. The physician counseled her on smoking cessation. Appropriate vaccinations were ordered, and an initial dilated eye evaluation was arranged. Neuropathy screening was deferred to the follow-up visit. At checkout, the receptionist scheduled a follow-up visit for Carla in 3 months. Repeat hemoglobin A1C, blood pressure, and lipid testing on follow-up will allow Carla, together with her healthcare provider, to monitor her progress and determine if changes in therapy are needed. She was given a lab slip and instructed to have her hemoglobin A1C and LDL cholesterol levels drawn prior to her 3-month visit. The nurse gave Carla a glucometer for self-monitoring of her blood glucose levels and provided written instructions on use. Carla was advised to check her blood glucose levels periodically. As you can see, the physician followed some of the ADA standards of medical care for treatment of individuals with newly diagnosed diabetes and introduced key lifestyle changes essential in achieving and sustaining treatment goals. It is important that providing lifestyle change recommendations does not result in a delay in the initiation of pharmacotherapy by healthcare providers. Use of pharmacotherapy is not considered a failure and, when needed, complements the benefits achieved through lifestyle changes. Now, let's look at the events that occurred prior to Carla's 3-month follow-up visit with her healthcare provider. Carla received an automated appointment reminder the day prior to her scheduled visit. The office received the results of the lab tests Carla completed prior to her visit. The medical assistant, nurse, and provider did not perform any pre-planning. The provider reviewed Carla's record quickly during Carla's appointment. At Carla's 3-month visit, her hemoglobin A1C is lower but still above the goal of 7.0. Her blood pressure and LDL cholesterol levels are above goal as well. While she has been taking her anti-glycemic and antihypertensive medications, Carla has not been taking her cholesterol-lowering medication as prescribed. Due to confusion with glucometer instructions, Carla has not been self-monitoring her blood glucose levels. Let's review what occurred during Carla's 3-month visit. Her provider renewed her prescription for the oral anti-glycemic, antihypertensive, and cholesterol-lowering medications without modifying the dosages. Even though she was not at treatment goal levels, there was not any intensification of her treatment. The provider wanted to give Carla more time to work on lifestyle changes and was concerned she may not comply with an additional medication. Barriers to adherence to her cholesterol-lowering therapy were not addressed. Carla had tried to quit smoking twice but was still smoking 1 pack a day. Her doctor acknowledged that this is difficult and encouraged her to keep trying. She has not attended a diabetes self-management education program, or DSME, and has not set a self-management goal. Carla received a lab slip for a repeat hemoglobin A1C to be done 1 week prior to her 6-month visit. After the visit, the office receptionist scheduled a follow-up visit for her in 3 months. Let's check with Carla 6 months after her initial diagnosis. Her physician's office followed the same pre-visit routine as last time. Carla has made little progress with lifestyle change, and her A1C level remains above goal. She forgot to take her blood pressure medication that morning, which she feels explains her blood pressure being elevated. Her provider decides not to make any changes in antihypertensive therapy. Her provider adds a second oral antiglycemic agent to intensify treatment for her diabetes. Her provider chooses an agent based on his or her preferences and not Carla's. She continues to smoke 1 pack of cigarettes a day, and her provider again advises her to quit but does not provide pharmacological support for smoking cessation or refer her to other cessation support services. Her provider encourages her to continue working on healthy lifestyle modifications and to be sure to take her medications daily. At checkout, Carla schedules another visit in 3 months and receives laboratory orders for a hemoglobin A1C to be completed 1 week prior to her scheduled follow-up. Over the 3 months following her visit, Carla has had some side effects from her second antiglycemic agent and believes it is contributing to further weight gain. Frustrated, she has not been consistently taking the second agent for her diabetes. She is also unable to make her scheduled follow-up appointment now 9 months after her initial diagnosis. Because Carla misses her appointment, the receptionist sends her a letter asking Carla to reschedule as soon as possible. Carla calls 2 months after receiving the letter and schedules her appointment for the following month, approximately 12 months after her initial diagnosis of diabetes. She has run out of her medications and requests refills. 12 months after her diagnosis, Carla's blood pressure is 142/80, her hemoglobin A1C is 8.0, and her LDL cholesterol remains in the 150s.
Let's imagine a different scenario. Carla's physician and the office staff recently participated in a training session about practice redesign and translating guidelines into action. The office began a process of care transformation in order to manage their patients newly diagnosed with diabetes more efficiently. They were now committed to helping their patients with diabetes attain their glycemic control quickly and efficiently. As a result of the process redesign, Carla's care team members were able to take immediate and appropriate action once she was diagnosed with diabetes and at each subsequent office visit.
Let's review Carla's situation. She presented with symptoms of increased thirst, urination, and fatigue. Her healthcare provider suspected diabetes as the cause of her symptoms. A hemoglobin A1C level was measured and was 9.1%. Her diabetes diagnosis was confirmed on repeat testing, and follow-up was arranged with Carla within 2 weeks to discuss her lab results, which included an elevated hemoglobin A1C, elevated LDL cholesterol levels, and blood and urine tests to assess baseline kidney function and screen for albuminuria. Her blood pressure on follow-up was 150/88, and she reported smoking about 1 pack of cigarettes a day. Let's review the treatment recommendations Carla's healthcare provider made. Her provider recommended diabetes management plan included lifestyle modifications, such as healthy eating, physical activity, weight loss, and smoking cessation. Prescription medications, including an oral antiglycemic agent, an antihypertensive agent, and a cholesterol-lowering agent. Her provider reviewed the indications for the medications and asked Carla to restate the information reviewed as she understood it. Carla was referred to medical nutrition therapy with a registered dietitian. The physician also discussed the importance of patient involvement in her own care and asked Carla to identify a self-management goal. Carla set a self-management goal of eating healthy to improve her energy levels and minimize symptoms associated with elevated blood sugars. Her action plan was to eliminate desserts after meals to make progress toward her goal. Her provider documented her goal and action plan in the Electronic Health Record, or EHR, for review on follow-up. The physician recommended attending DSME. The physician counseled her on smoking cessation similar to the previous scenario. She was also referred to a tobacco cessation program in the community and prescribed a nicotine patch. After her appointment with her provider, the nurse entered the exam room to address any remaining questions or concerns. Carla was given some additional information on her diabetes diagnosis and on important lifestyle changes. She was also given a list of the medications she has been prescribed and how to take them. She was provided a glucometer by the nurse who demonstrated how to use the device and instructed Carla on the recommended frequency of self-monitoring and how the readings will be utilized as part of her treatment planning. Appropriate vaccinations were ordered, and an initial dilated eye evaluation was arranged. Neuropathy screening was deferred to the follow-up visit. The nurse flagged the EHR as a reminder that she must perform a screening foot exam on follow-up. At checkout, Carla was told to schedule a follow-up visit in 3 months. She was given a lab slip and instructed to have her hemoglobin A1C and LDL cholesterol levels drawn 1 week prior to her 3-month visit. The office's focus on diabetes means that the date of the diabetes diagnosis is documented in the patient's medical record. The Quality Improvement Director worked with the EHR vendor to get a date of diagnosis field added to the EHR. This reminds the care team that Carla is newly diagnosed with type 2 diabetes, so that her diabetes care can be planned and tracked accordingly. Because the office had begun using a diabetes registry that is linked to the EHR, they were able to enter Carla's data at the time of her diagnosis of diabetes. This will help the provider to track her progress and determine necessary and recommended treatment changes over time. Carla's healthcare team meets quarterly to review their team member roles and responsibilities, any updates to clinical guidelines and clinical practice, and diabetes registry data. As part of their patient-centered care approach, the nurse called Carla 1 month after her diagnosis to assess her status and to offer individualized support. If you recall, Carla was told to follow up in 3 months. Let's see how she is doing. On the day before her 3-month visit, she received an automated reminder phone call to confirm the visit. On the morning of Carla's visit, the nurse and medical assistant followed pre-visit planning guidelines developed by the office staff and prepared the lab orders for the patients scheduled for the day and reviewed their preventive care needs. Implementation of standing orders for standard lab work allowed the nurse to order lab testing. The nurse printed the lab slips to give to Carla and the other patients for the day. The slip had instructions to complete testing 1 week prior to Carla's next visit. The nurse also flagged the EHR as a reminder for the care team to check on smoking status, to assess Carla's progress toward her self-management goal, to determine if Carla had attended the diabetes self-management education program and medical nutrition therapy. As a result of health systems change, the healthcare team members' roles and responsibilities were clearly defined, facilitating coordination of care during Carla's follow-up visit. On the morning of Carla's appointment, the healthcare team members huddled for 10 minutes to review the day's patient list and to address any pertinent issues or concerns for the day. Her provider then reviewed previous clinic visits and lab results in the EHR prior to meeting with each individual patient. In addition, the receptionist assisted with check-in and encouraged Carla to complete a short form listing her primary concerns for her care team. The medical assistant obtained vital signs and completed the medication reconciliation prior to Carla's visit with her physician. At her 3-month visit, Carla has made some progress on her self-management goal of eating healthy by eliminating dessert after the majority of her meals. Her hemoglobin A1C is decreased, but not yet at goal. Her blood pressure is at goal. She has been more physically active and she has stopped smoking. However, she has not attended medical nutrition therapy or DSME and has not been taking her cholesterol-lowering medication. Let's look at what happened at the 3-month visit. A copy of her lab results with information on trends in her results was given to Carla during her visit. Her provider reviewed the results and praised Carla for improved control of her blood glucose, blood pressure, and LDL cholesterol. Because Carla's hemoglobin A1C was still above the treatment goal, a second anti-glycemic agent was recommended by her provider. No further change in blood pressure medication was needed as Carla's blood pressure was at goal. Carla's physician asked her about barriers preventing adherence to her cholesterol-lowering therapy. She said she had a hard time remembering to take the medication in the evening, and she was also not clear on why the medication was important. They talked about the benefits and reasons for the medication and identified some strategies to help Carla remember to take her evening dose. She reported progress toward her healthy eating goal and was congratulated and encouraged to continue to create action plans, bringing her closer to her self-management goal. For further support in her self-management, she was encouraged again to meet with the dietitian for medical nutrition therapy and to attend DSME. Because she had successfully quit smoking, her physician acknowledged her success. No further guidance was needed. After her visit with the provider, the nurse meets briefly with Carla in the exam room to address any remaining concerns she may have after her discussion with her provider. Additional strategies for medication adherence were provided. The nurse completed a foot exam to screen for diabetic neuropathy. Carla was given contact information for medical nutrition therapy, and the receptionist helped her to register for the next DSME program. Carla received her lab slip for a hemoglobin A1C and LDL cholesterol level 1 week prior to her next visit. The office receptionist scheduled a follow-up visit in 3 months. Let's summarize the care transformation strategies employed at Carla's office during the 3-month visit that supported appropriate intensification of therapy and improvement in the overall patient experience. Prior to Carla's visit, her care team established clear roles and responsibilities for each of its members, with a focus on pre-planning and proactive care. Because the initial date of diabetes diagnosis was documented in the EHR and Carla was added to the diabetes registry on her previous visit, her progress toward treatment goals is more easily tracked and followed. During the visit, Carla was provided with her lab results, which her provider reviewed with her. This was done to facilitate her taking an active role in her care. Her self-management goal and previous action plans were also reviewed, and her efforts were documented in the EHR. Carla's physician received a prompt that she was not at goal for A1C and that treatment intensification should be considered. The prompt did not stop there, though. It required the provider to state whether she would intensify treatment, and if not, why. The patient care team addressed Carla's barriers to adherence to cholesterol-lowering therapy and offered support and strategies to overcome those barriers. The team also distributed tasks such as the foot exam and medication reconciliation from the provider to the nurse and medical assistant, supporting more efficient workflow. Let's check with our patient again. It's been 6 months since her initial diagnosis. She had met with a dietitian for medical nutrition therapy and attended DSME. Carla has met with the physician twice since her diabetes diagnosis, at the initial visit and at 3 months. Her physician's office followed the same pre-visit routine as last time. Here, you can see that Carla has met all 4 of her treatment goals due in large part to her medication adherence, improved self-management skills, and healthy lifestyle changes. As a result, the physician does not make any adjustments to her treatment and provides positive reinforcement for all of Carla's efforts and for the progress she has made. She scheduled another visit in 3 months, or 9 months after diagnosis, and received laboratory orders for a hemoglobin A1C. She was advised to have this completed 1 week before her 9-month visit. The 9-month visit for Carla is an interesting one. She misses her appointment. Per clinic policy, the office receptionist calls to reschedule Carla's appointment. She asks what difficulties prevented Carla from making her appointment and offers assistance. She learns Carla is having transportation issues. The receptionist sends a bus pass in the mail to Carla that day and reschedules the appointment for later in the week. At the 9-month visit, Carla remains at goal for her blood glucose and blood pressure control. She continues to abstain from smoking. Her doctor reviews her lab results and blood pressure reading with her during the visit. No further changes are needed in her medication. Because she reports feeling a lot of stress, her physician counsels her on possible stress reduction techniques. The nurse meets briefly with Carla to assist with any other needs. After some thought and review of her options for stress relief, Carla creates a new self-management goal targeting stress reduction. To make strides toward achieving this goal, Carla establishes that her action plan for the month will be to join a local gym to increase exercise. 3 months later, Carla returns for her 12-month visit. In the year since her diagnosis, she has controlled her ABCs and made progress toward her self-management goal of stress reduction. She's looking forward to staying on track and successfully managing her diabetes.
As we critique both approaches to care, we can see a pattern in provider, patient, and office factors that impact, either positively or negatively, the ability to reach treatment goals. When Carla's physician's office used a multifactorial approach to diabetes care, the multiple causes of clinical inertia were addressed. Multifactorial approaches have been proven to be more effective at combating clinical inertia and thus attaining treatment goals and outcomes earlier. When Carla's provider took a passive approach, the key treatment goals were still monitored, but the provider did not have office procedures in place to assure that treatment intensification was considered and implemented. These two approaches result in vastly different clinical scores and outcomes 2 years from the initial diagnosis. The Carla who was intensively managed has achieved all of her treatment goals. The passively managed Carla has shown some improvement, but did not reach goal for any of her ABCs.
The Carla that received intensive treatment achieved an A1C level of less than 7% rapidly within 6 months. With continued glucose control, she is likely to preserve her beta cell function for at least 3.5 years. These factors combined lead to a reduced risk of diabetes complications and mortality. For each 1% reduction in mean hemoglobin A1C, Carla will have a 21% reduced risk of any diabetes-related endpoint, a 14% reduction in the risk of myocardial infarction, and a 21% reduced risk in diabetes-related death. On the other hand, the passively managed Carla has spent up to 2 years with a hemoglobin A1C level above 7.5%. Due to her suboptimal diabetes control, she likely experienced an earlier decline in beta cell function. This decline may result in prolonged hyperglycemia and an increased risk of diabetes complications. If Carla's A1C level were to increase, her risk would be even greater. 4 years after diagnosis, the Carla who has been proactively treated is doing quite well due to early and intensive treatment, ongoing quality diabetes care, active patient engagement, and support for effective self-management. Meanwhile, Carla finds out that the retinopathy detected at the time of her diabetes diagnosis had progressed due to poor glucose and blood pressure control. She now requires laser surgery to lower her risk of developing blindness. 8 years after the diagnosis, early managed Carla. Carla is feeling good and is able to do many of the things she always hoped to do in the future, such as play with her grandkids. Passively managed Carla. Unfortunately, Carla experienced a myocardial infarction, hypertensive crisis, dehydration, and hyperglycemia. 20 years after diagnosis, early managed Carla. As she grows older, Carla has managed her diabetes well and continues to get positive support from her physician and family. Passively managed Carla. Carla's complications from poorly controlled diabetes continued to worsen. At this time, she has been diagnosed with end-stage renal disease and has started hemodialysis.
This video provided just a few of the many ways you can use early and intensive treatment to help your patients who have been newly diagnosed with diabetes. It is our hope that this video has enabled you to define and recognize clinical inertia, understand the rationale for early and intensive treatment for patients newly diagnosed with diabetes, and identify useful strategies which you can implement in your office.
If you are interested in learning more about diabetes clinical inertia, I encourage you to visit the Time to Treat page on the National Kidney Foundation of Michigan website. This has a wide variety of resources, including the Time to Treat Literature Review Summary Report. In addition to a summary of clinical inertia for diabetes management, the literature review has abstracts from key articles used to prepare this video, as well as several other care transformation strategies.